interatrial septum by the 3D transesophageal echocardiography. And here comes the article that I mentioned in the previous image. You could measure it, you could see it from the right atrial perspective and the left atrial perspective. In the right atrial perspective, you are using the 3D zoom, and then you rotate the image and tilt it to make it in the face of you. This is the view from the right atrial perspective. And this is what's so-called the Rattle 90 maneuver that our friend Dr. Hani Mahmoud, who is an expert in field, had published this before. You are putting a 3D zoom box over the interatrial septum, including the superior vena cava opening, and then you rotate anti-clockwise around the z-axis, and you tilt 90 degrees axis. Then you are left with facing this view. This is you are looking from the right atrium. So why you are not seeing anything from this? Because this is a blood pool. By decreasing the gain, you will see the septum itself. And this is example of what you do. You are now seeing the interatrial septum from the bicaval view, and then you will put your box to include the SVC. You will have this view. So you rotate anti-clockwise. Okay, so make the SVC in the above. Okay, this is the image. So you rotate above, and then you are tilting the image to be facing you. And then you decrease the gain a little bit to have the blood pool to disappear, and you see the septum very clear. And now this is also from the recent article that the view that you can see from the left side, or from the left atrial perspective. So what is the advantages of the 3D echocardiography transesophageal? This is an easy and quick definition of the ASD morphology. It has an accurate detection of maximum diameter of the ASD, and it's accurate in the diagnosis of multiple ASDs, as we will see. So just this is a view from the right atrial emphasis view. You can see the defect is very clear with all the borders all around, and you see it from the left atrial perspective on the right side. It is very clear here. This is another example of what you see in the RA view and LE view. And here you can see it in action and live. And also the machine can give you the ability to see it from the left atrial perspective and right atrial perspective simultaneously at the same time. And also you can see here, these are the different shapes. When you see it from the 2D, you will see just a drop out of the interatrial septum. But how it looks like, you will not get this by 2D in any mean. You only could see this by the 3D. So it may be round, maybe oval, maybe rhomboid in shape. So the shape, you will see it is better to see by the 3D modality. Also, you could see from here that you have two defects in the interatrial septum. Yes, when you put your color, you will see two defects, but you will not define which one is bigger, which one is larger, and which one had a specific shape. Also, there is an important, if you look at the image on the left side, you can see that you have two jets. So you see two jets. So you have two ASDs. But when you look by the 3D, you will have a multi-fenestrated ASD. So this changes your decision for the intervention. Also, this is a multi-fenestrated interatrial septum from the right atrial perspective. Okay? You cannot see this that clear except you are using 3D echocardiography. This is another example of multi-fenestrated ASD. You can see multiple defects in this image. So let's know about the sizing. How to measure it? In the sizing of the ASD, you are concerned by two things: the defect size itself and the rims around the defect. So if you go with the 2D, you have to go through all the angles around the defect and measure it, like this, in the 0 and 30, 60, 90 degrees. And then you take the measurements and take the widest and narrowest measurement. Making sense. But sometimes your angle is not aligned to get the widest diameter, like you are seeing here. When you look at it in the 3D, you are taking a measurement and you consider it's the widest, and actually it's not the widest. So this is how it looks like. When you use the 3D, you see the defect in all the dimensions and the shape of the defect. And remember, never to measure on the generated 3D image. You always measure on the axial images. So the images in the generated image give you an idea about what are you seeing, like we will see later. But for taking the accurate measurements of the defect, you should do this on the axial images, okay? So also remember that the ASD, it's not a fixed defect. it has a dynamic nature. So it decreases in size and increases in size with the cardiac cycle. So it decreases size in diastole when the atria contracts, and it dilates in the systole. And you should build the sizing of your device on the widest diameter in the widest part of the cardiac cycle. Okay? See, so now you have measured your size. So what about the rims? You have 5 rims that we are concerned about. The aortic, which is the least important, the atrioventricular, or the AV valve, or the mitral rim, the superior vena cava rim, the inferior vena cava rim, and the posterior rim. A safe margin is 5 millimeters or more. If you have less than 3 millimeters, you have danger. And all of this apply to all the rims except the aortic rim. Okay? And this is from one of the previous studies that has seen that the aortic rim deficiency may be found up to 65% of patients with secondum ASD, which is a very big number. Okay? And you have multiple rim deficiencies in 7%. You may have sufficient rims in only 24% of your patients. So you should be aware of this. Okay? So if you have a deficient aortic rim, this is, as we had said, this is very common, and this is not considered an absolute contraindication, but it's technically more demanding and needs some tricks during the implantation, and usually associated a higher risk for erosion if completely absent, or what's called the bald aorta. If you don't have a rim at all, you may have a small rim like 1 or 2 millimeters, but if you don't have a rim at all, it's called bald aorta, and it carries some risk of aortic erosion. Now, let's go for the rims. How you measure your rims? If you're using the 2D, you should go through all the angles around the heart so to measure it. Like you can see here from the different parts, you see these images. But like you see, that's here from the mid-axis, the short axis, the bicaval, the 4-chamber view, and you measure your rims. But in 3D, you can take this in only one shot. Like this, you are seeing here all the rims. I think we all can see that there is enough tissue around the defect. So without even measuring, you can say that you will have a stable device in this because you have a sufficient rims. And also, it gives you a short glimpse of defected rim without needing to measure, like the image that you had seen in the below. You have here a deficient IVC rim. You have here a deficient aortic rim. Okay, you have deficient SVC rim and deficient right pulmonary vein rim if you're looking from the left atrial perspective. So you can see just with a glimpse, you can say that they have a deficient rim or enough rims even without measuring. And this is how you measure this. As we have seen, measurements by millimeters is done only in axial images. And also this is an image from the most recent article about the use of 3D. Also, it's not just about the size. It's not just about the rim size, but also it's the consistency of the defected rim. So if you have an interatrial septal aneurysm or a redundant septum, this could change your decision, like you are seeing here. Now you are seeing a flimsy septum. How it extends, where it reaches, and here comes the role of the 3D echocardiography. It's very clear here that you have seen that the part that is aneurysmal is reaching the roof. Okay, so this will make your device will be non-stable. But also, if you look at this image at a glimpse only, you have seen some redundancy, but it's not reaching the roof. So your device may be put here and safe. You are not worried about dislodgement of the device. Another very close example to the interatrial septal aneurysm by the 3D echocardiography. Also, this finding, which is called the ridge of the interatrial septum, that is very difficult to be seen by the 2D echocardiography. And I can say that I only had seen this by the 3D echocardiography. From the left atrial perspective, you can see a ridge. And this ridge could not be seen by the 2D echocardiography. You can only see this by the 3D echocardiography, and it sometimes may interfere with introduction of the device across this and the stability of the device according to its size and direction. So you should be aware of this and note this clearly in your report when you are trying to send the message to the interventionist. And also, you look by the 3D echocardiography for the pulmonary veins. If you have an abnormal pulmonary veins drainage, this is important. And this image are the courtesy of Dr. Ahmed Mohsen. This is clear images taking the pulmonary veins and the pulmonary veins flow. And also, before going for planning the closure device for the ASD, you look for the left atrial appendage thrombus and the left atrial imaging capacity. If you have a thrombus, this is a contraindication to putting the device. So after all of these data, you will ask yourself a question. Is this defect suitable for device closure or not? Which defect should you close? Secundum ACD measuring less than 35 millimeter in its widest diameter, and we have said that the role of 3D for taking the widest diameter is very important. You should have adequate trims all around except the aortic rim. You have some septal redundancy reaching the root of the atria. This is a contraindication for the risk of embolization of the device. You don't have significant right to left shunting and no other finding requiring open heart surgery. Like if you have abnormal venous drainage or any other congenital anomalies, so this patient is going to surgery anyway. So send him and close it surgically. So what are the contraindications to the percutaneous closure? Small ASDs with QP and QPS less than 1.5, single large defect over 38 millimeter, because no device will adapt this and will have a very high risk of embolization and erosion. Defect is too close to the SVC or IVC, which means deficient trims. Abnormal pulmonary venous drainage or associated other congenital anomalies. Another hot issue is that if you have ASD with severe pulmonary arterial hypertension, this is a contraindication to closure of the ASD, intracardiac thrombi, and severe allergy to iodinated contours, but this could not be considered as a complete contraindication, as you may use only the echocardiography during the closure of ASD defect. This is how the device that we are using, which is called the Emplazer, how it used. It's two discs that collapse on each other. There's a disc, a bigger disc at the left atrial side, and then it's put over the left atrium, and then another disc from the right atrium, a smaller one, will grasp the interatrial septum in between, and this is the device closure of the ASD. And these are graphics of how the device closure works. The left atrium, the bigger one, and right atrium and bigger one, and it's grasping the septum in between, and this is how it's done during the procedure itself. Okay, and this is how it appears by the 3D echocardiography. Never clear. You are seeing the two discs clearly and the grasping and how it appears, and even you can see here with this good quality images the wires of the device itself, which is amazing. So let's go by step. You now confirm that you have an ASD, and you confirm this by the color. And then you are passing, look at the image on the left side. You have your device or your wire is passing through the defect itself. You can see this very clearly by using the 3D echocardiography, and you see the wire all across its course. And then you inflate the left atrial disc, and you pull back, and then deploy your right atrial disc. And this is the final result with the device in place, and see here the device in place without any residual shunts. Again, this is a step-by-step, the left atrium and the right atrial discs and the grasping of the interatrial septum. These are another examples of the grasping of the interatrial septum by the 3D. I think that the image speaks for itself. It's amazing. Now, let's get to some hot topics. Now we are faced with double ASD. You have two ASDs. Is it a contraindication to closure? Actually, it depends. If you have it's two separate devices and you can put two small occluders to occlude your both defects, you can do it. So double ASD is not a contraindication to the intervention. And if you have a small rim in between, so you cannot put two devices, you can use even a bigger device that can cover both the defects itself. This is another way. But you should be sure that after deploying the device, you are not interfering with the mitral or the aortic valve function, especially the aortic valve if you don't have aortic rim. So how you could say this is a successful ASD? You have no trivial or less than 1 millimeter color jet width. You have a small or even very small or tiny, or what's called a trivial jet across the septum. But if you have a residual shunt that's called color jet with a width 2 to 4 millimeters, this is a considered residual shunt, and patient with residual shunt is considered to have a failed procedure. So you may have some complications of the percutaneous ASD, like the device or band embolization, cardiac arrhythmia, or cerebral embolism, like the catastrophe you are seeing here. Your device is floating inside both atria. This because of the right or the bad selection of the device size from the start. And here comes a catastrophe by the 3D. You are seeing your device is moving across the atria and the left ventricle is freely mobile inside the cardiac chambers. So my conclusion that closure of ACD requires meticulous echocardiographic assessment prior to the procedures. The 3D-TE saves time and help more for accurate assessment of ASD shape, size, number, REMS, and overall suitability for device closure. The 3D-TE is very important during the ASD closure procedure itself, and thank you for your time.
Thank you, Ahmed. This is very interesting, and you are complete the images for how to assess defect for closure. But what about BFO? Does it apply the same
Yes.
technique for choosing the case for our
Yes.
optimal case?
Yes.
The REMS, the adequate REMS?
Actually, the REMS is not a problem with the PFO, except
Yes.
you have an interatrial septal aneurysm, and that reaching the roof of the atria.
If you have an interinterceptor aneurysm, this
Aneurysm
is,
that reaching, yeah, that make the device unstable later on
Yes.
and have the tendency
this is
to
a
embolize.
contraindication.
Thank you very much. طبعا البي اف او دي قصه ثانيه خالص مش عايزين نخش فيها لان it's not a matter of rims. Usually they are intact. It might be a tunnel, and the length of the tunnel speaks a lot, and
Yes.
the choice of the device is going to differ according to the length of the tunnel, according to the distance from the SVC and the distance from the aorta. So it has many other. It's something else rather
Yes.
than the ASD. It's the same technique but different evaluation.
Yes.
Something else I just want to mention, that it's, yes, we are just closing the secundum ASD as the guidelines, but the closure of the sinus venosus VSD is coming into practice by stenting, so this is something else to be considered nowadays as well.
Yes.
Thank you very much. You don't want to say any comments?
May I have a question? First, we are totally thankful for this elegant lecture.
Thank you.
May I ask, how much does the 3D echo add for the evaluation of the consistency or the quality of the ASD rim, and consequently the sizing of the device or the feasibility of closure or not?
I think the first step is heads in the sizing of the device, because the size, as we have changed, the shape of the ASD is a little bit weird. It's not always circular. So the 3D give you the widest diameter in a very accurate way, even if you tried by the 2D, if you're going up on the transvagal by 5 by 5 angles, you will not get it like you have 3D. So this is the size. About the REMS, you can see, you can just have a single full volume or 3D zoom image, and you take all the measurements and within a very clear way, and also the interinterceptor redundancy, whether it's reached the roof or not, the 3D help you a lot with determining it's reached the roof or not.
Plus, you just didn't mention about the balloon sizing, which is an important step,
Yeah.
especially in the redundant septum.
Yeah, yeah,
The 3D will do
will help you with the balloon.
will help a lot in this.
Yes.
Thank you very much.
Thank you very much, Ahmed, and thank you for all speakers and all audience, and we can close. لسه في حد؟ لسه في another one? Oh. So please. I think that's all enough. So. Yes, please.
We are waiting for your paravalvular leak.
First of all, I'm really very happy that the whole salon is full, still full, and thank you for your patience. And today's third topic is imaging in paravalvular leak closure. And the questions in a PVL case is, if the patient has symptoms, well, how is the laboratory tests? Sorry, I will use this. And what about the severity of leak? And shall we prefer medical, surgical, or percutaneous method? And what about the incidence of PVL? It's after MVR 2 to 12%, after AVR 1 to 5%, and after TAVR 17%. And in TAVR, self-expandable valves have more PVL than comparing to balloon expandable valves, but still there is no head-to-head comparison studies on this topic. And what are the risk factors for a PVL case? Of course, mechanical valve implantation and annular calcification, as you can see here. This is the most extreme, one of the most extreme examples. You can see also myocardial calcifications here. And infective endocarditis cases, of course, those patients have fragile tissues and previous valve surgery patients as well. And what are the risk factors for a TAVI PVL? Annular calcification first, and second is incorrect procedural valve sizing. That's why valve sizing is very important, because we all know that paravalvular leak after TAVI is one of the most important predictors for the mortality of a TAVI patient. So it's very important. And what are the reflections of PVL to clinical pictures? And what are they related to? Of course, the severity of PVL is very important. Hemodynamic effects are very important. And secondary results like the dilatation of left heart chambers and PHT, pulmonary hypertension, and if there is any vegetation, thrombus, or pannus. And most patients are asymptomatic, and the 1 to 5% of the patients are symptomatic. And if you have a recent, resistant, unexplained heart failure symptoms, and hemolysis with or without anemia, and if you have an alteration of auscultation findings, and if you have such markers, you have to do further investigation to check if there is a paravalvular leak. What about imaging? Again, I'm emphasizing multimodality imaging, transthoracic echocardiography, TOE, 2D, 3D TOE. You can use eyes, we don't use it at the moment at our center, and fluoroscopy, CT, fluoro-CT, and even cardiac MRI can be used. And this is a very nice paper from Jack Case reports in 2022, which tells the importance of multimodality imaging for a successful paravalvular leak repair. And severe PVLs are more common in mitral, as I've already mentioned, and we also see rarely in pulmonary and tricuspid positions as well. And echocardiography plays a very essential role in the initial diagnosis, in the identification of suitable patients to undergo transcatheter intervention, intraprocedural guidance, of course, and for the follow-up as well. And transthoracic echocardiography is the initial, of course, the most practical and most accessible method for paravalvular leaks as well. But for the mitral prosthetic valves, there is a problem with acoustic shadowing and reverberation artifacts, and you can see it in this case as well. But there are some indirect findings of PVL on transthoracic echocardiography, like motion abnormality of the prosthetic valve, dilated or hyperkinetic LV, and if you have a E velocity with PV Doppler more than 1.1 meter per second, and if your mean mitral gradient is equal or more than 5, if you have an LA dilatation and mean or unexplained pulmonary artery systolic pressure increase, you have to be very alert and you have to investigate it further with transesophageal echocardiography. And what are the added values of 3D TOE? Of course, better localization of the leak, better definition of the size and shape, which I will tell in the following slides, and of course, guiding of percutaneous closure. All of these features made this technique the gold standard for a PVL evaluation. And of course, we may encounter some problems, such as stitching artifact, dropout artifact, as Dr. Ahmed Mohsen already mentioned, and we can sometimes, for example, we heard, personally, I didn't experience, but I heard from senior professors that in the previous times, they saw something like a defect, but they gave it the patient to the operation, but at the end there was no actually paravalvular defect. So sometimes it can be confusing. We always have to compare 3D images with 2D scanning at each angle of the TOE, because sometimes we can see dropout artifacts. We may think that it's a defect, but sometimes it's not. So please compare with 2D images as well. And of course, this is the standard en-face view of the mitral valve. When we put the aortic valve to the top, the nomenclature of the paravalvular leak is a little bit different, of course. We are calling it like the defect is at 1 o'clock position, 2 o'clock position, between 3 and 4 o'clock position. Generally, the leaks are here at 10 and 11 o'clock position and 5 and 6 o'clock position generally. And this is our typical surgical view, en-face view for the mitral valve. Again, aortic valve is on the top. And if you scan the mitral valve at different angulations, you will see different parts of the annulus, of course. Here we have an example. Here we have the big bicommissural view. LAA is here, the lateral part, and the septal part. Definitely the defect is in the septal part. And if we go to the en-face view, we see that the defect is really at 3 o'clock position here. And of course, another important issue is grading of the PVL and motion of the prosthetic valve. For the grading of the PVL, one of the markers is motion of the valve, because it's an indicator of dehiscence, or rocking motion is really showing dehiscence of the valve. It's very important, and mostly it is severe paravalvular leak. And we can use vena contracta if there is a single defect. PISA has no validation, but if it is larger, it definitely supports a severe PVL. We can utilize pulmonary vein flow reversible. It is specific but not sensitive for severe PVL. We can also use jet velocity density and regurgitant jet area. Actually, we are combining all of them in a clinical scenario as well. You can utilize as well the 3D color area approach as well, and it is not easy, but we can use it too. And after we are sure about the severity, localization, shape, and number of defects are important. And for the anterolateral defects, we use the transeptal approach. And if the leak is posterior or medial, we use mostly retroaortic and apical approach. I can show it here too. If we have a lateral one, we are using transeptal approach. And we can also utilize retrograde and the transapical for the medial ones especially. And about the shape of the defect, you can see the crescent-ring defect and slit-like defect, oval defect, and tunnel-shaped defect as well. And here there is an example. This patient was a 75-year-old male with dyspnea, hemolysis, and radiocardiac surgery. You can see the crescent-ring defect here, but when you tilt the valve, you will see that. When it is like that, we see with the color Doppler only a small regurgitant jet. So we had to go with a PVL, percutaneous PVL closure, because the patient had no other chance after 2 surgeries. But at the end, we were successful because after we put a single device at 11 o'clock position, the result was quite good, and we didn't need to put any other device because there was no residual regurgitation. By the way, I have just a little charge. Maybe I can get my charger from my bag to be able to continue. And there are suitable and unsuitable PVL closure items. And for the suitable valve paravalvular leak closure, If the defect is small, yes, if the defect is small and if the suture ring defect distance is more than 5 millimeters, if we have a single defect and a small tunnel-shaped defect, those are suitable for paravalvular leak closure. Can you help me for sharpening? Sorry. As we have lots of lectures, my computer's charge is not enough, sorry. I think yes. And if we have a suture ring defect distance less than 2 millimeters, and if we have large defects, and if we have an extensive leak, which means more than 25% of the suture ring, if we have a slope tunnel shaped defect and a multifenestrated defect, if we have a rocking valve, if we have a dehiscence, and a calcific paravalvular tissue, those are not suitable for percutaneous paravalvular leak closure. And about the aortic leaks, it is more difficult actually than the mitral prosthesis due to distortion of the aortic valve plane obscured by reverberation artifacts and acoustic shadowing of the prosthesis. And we can use short axis, long axis, and deep transgastric views. And of course, dehiscence again, rocking motion, leaflets, motion restriction, as you can see on the right-hand side, and the thrombus and the pannus, those are contraindications for percutaneous closure for aortic valve. And what are the criteria for severe paravalvular leak? It is very similar to native valve regurgitation. If we have a short PHT, less than 200 milliseconds, if we have multiple jets, it's not always. If we have small multiple jets, it's not severe, but if we have multiple bigger jets, it's more consistent with a severe PVL. If we have a holodiastolic flow reversal in the descending aorta, it is also mostly consistent with severe PVL, but in older patients, it's a question mark. And if Dr. Ahmet Farid already mentioned in his lecture, more than 30% of extensive color Doppler is also consistent with severe PVL. If it is less than 20, it's consistent with mild paravalvular leak, and LV diameter is also important. This is a mild PVL example. You see it's like 10 to 15% of the whole annulus. And this was a drawing of mine from COVID era, as you can understand from this guy. This is a detection of paravalvular or aortic regurgitation after TAVR with color Doppler on transthoracic echocardiography. The tricky point is here, if you have a paravalvular leak adjacent to anterior mitral leaflet, okay, here, this is generally the posterior part on the transthoracic echocardiography. You can say, if you see here, this is the posterior part of the aortic valve, and the vice versa is anterior part. And this is a moderate degree PVL with a PHT of 350 milliseconds. And you can see here multiple jets, but not very big jets. And of course, paravalvular leak is really something very bad. Why? Because it makes symptoms, particularly after TAVR. If you don't have a native valve aortic regurgitation, and if you have mild to moderate aortic regurgitation at the end of the procedure, the patient gets slowly symptomatic. It is severe. The patient will definitely have symptoms after the procedure, and you have to do something with that. But if you have at the beginning a native mild to moderate aortic regurgitation, if you have after the procedure mild to moderate regurgitation, the patient can tolerate it. But vice versa, it's difficult. And about the intraprocedural guiding, of course, 3D TO is very important for defect sizing and localization, as I kept mentioning. And real-time, you can utilize real-time imaging, and you can check the perpendicularity of the device and orientation of device. You can see the manipulations of catheter, and you can manipulate your interventional cardiologist, turn it like clockwise, counterclockwise, and so you can just orient your interventional cardiologist. And of course, at the end, you can assess your residual regurgitation with color Doppler. This was a successful procedure, so we don't have any residual regurgitation. And for lateral PVLs, superior transseptal puncture is better. For the septals, inferior transseptal puncture. And if we have an aortic plus mitral PVL together, and if we have a medial defect, as I've already mentioned, transapical approach is better. Our aim is always to cross the defect with help of echo plus fluoroscopy, and wire over the wire catheter device implantation steps are important, and we are assessing motion of leaflets. It is very important because sometimes you put your device and one of your leaflets, if it is a mechanical valve, it gets stuck. So you just manipulate, you turn it somehow, but sometimes whatever you do, it doesn't go on very well. So you have to stop the procedure and you have to give up percutaneous closure. We had such cases. In bioprosthetic valves, it is safer, but in the prosthetic valves, you have to check it definitely with fluoroscopy particularly. And again, I'm emphasizing this pericardial effusion. You have to check before the procedure if there is any pericardial effusion. And this was another case. You can see at 11 o'clock position defect, and those are the procedure steps and successful results. What do we use? We use mostly congenital vascular closure plugs, and there are different plugs in the market. For the post-TAVR PVLs, first we try the post-dilatation. Valve-in-valve could be an option, and as the tunnels are generally irregular and there is generally calcification, we prefer smaller devices actually. And this was another case. You see the transthoracic echocardiography, it's a medial defect, it's at 3 o'clock position. I showed this case before, just wanted to show one more example. And this was a very interesting case. This was published at, we presented it at EuroEcho, and it was also published at European Heart Journal case reports. And this young lady had a mitral valve replacement 4 months ago, but unfortunately the lady had an infective endocarditis and had her second operation after antibiotic therapy, but unfortunately she had again a paravalvular leak, and you can appreciate that it makes more than 25%, it's almost 50% of the whole annulus. But unfortunately, she was very young and she had no more option. She was just sitting, and the New York Heart Association class 4, she was hospitalized lots of times, and everything was terrible. And we had to go. This patient came from Cyprus to our center, and by ambulance plane, and we had to do it. Somehow we achieved, and after 4 devices, you can see that we put 4 devices one after the other, and at the end there was no residual mitral regurgitation, and this was, I think, 3.5 years ago, and the patient is still alive and comes to control, and she's very happy and doing everything, so we are happy too. And one more important topic is the fluoroscopic anatomy of left ventricle actually, because we can use this fluoro-CT technique for all structural cases, including paravalvular leak. So this, I was in Canada, in Montreal, at McGill University for learning this technique for 2 months. It's fluoro-CT, and it actually combines fluoroscopic images with CT, not only actually fluoro plus CT, fluoro plus echocardiography as well. And I was asking all the time, can we use it for paravalvular leaks as well? And my mentor and supervisor, Dr. Nico Piazza, was saying, yes, we can use. On my last day, we had a TAVI case, and we had a paravalvular leak, this case, and this was also published. And this case was, we chose a 26 millimeter Evolut R valve. And following deployment, the patients here, you can see, had a paravalvular leak. And after post-dilatation with 23 millimeter of balloon, there was still paravalvular leak. And we sent the TOE probe, and you can see there was a severe PVL. And at the beginning, the patient had no native valve regurgitation. And it was at 12 o'clock position. Here is the interatrial septum, here is the defect, and it is towards the left atrium with a 60 degrees angulation actually. So what did we do? We went in the cath lab, we went to the CT directly, and we approximated it. We thought that, we imagined that the defect is here because we know the TOE image, and it has to be around here. We put the hair cross perpendicular to the defect, and you know, CT has the MPR technique, and when we put the hair cross here, we will see at the same time the 3-chamber weave, 4-chamber weave, everything in 4 different windows. And what is important for us is the 3-chamber weave, because we will utilize it, we will put the same angulation to the fluoroscopy. What we did, I repeat it, we found the approximate area of the regurgitation using TOE as a marker. We put the hair cross perpendicular, we found the 3-chamber weave, and we lateralized the defect, because what we had done was, we sent the wire, because the defect was here, we have to lateralize the defect, because at the end, we will send our wire adjacent to the wall of the ascending aorta. And it was on the left part of the left wall of the ascending aorta. And we went to the same angulation with this image on fluoro, and we said, okay, our defect will be on the left side, and we sent the wire directly, and everyone knows 3D imaging in aortic valve is not easy. It's not like mitral valve. So finding the correct places, sometimes it takes 1 hour, 2 hours. It's very difficult for aortic paravalvular leaks. So, but if you find your angulation on CT, and if you go to that point, you will directly cross the leak, which happened here. And we closed the leak with amplas vascular plug 2, and here, and the plug is here, and there is no residual aortic regurgitation, and before and after plugging. And how long did it take? It took only, how much? 12 minutes. It was a really very good question, because it reduces the amount of contrast, amount of the radiation, amount of sedation you give. So it's a quick procedure. And what did happen afterwards? After I was back home, we had a very similar case, and we did with the same method, and we presented it at EuroEcho again in 2019 in Vienna. So, and this was very similar. Coincidentally, it was at the same location, the PVL, but the difference was we didn't do it ad hoc, because the patient was referred to us, and we checked first the TOE, and it was really severe, less than 200 milliseconds. And we went to the CT, because the patient had the previous CT. Even if you don't have the CT, you can do the CT, a new CT, and you can just imagine where the location of the defect is from TOE. It is the interatrial septum, it is in the left atrium. It's like 60 degrees again, 60 to 70 maybe, and it should be around here. We put the crosshair perpendicular to the expected defect, and we go to the 3-chamber weave, we lateralize the defect, we find the angulation, and we find the same angulation on fluoro-CT, and in this case, we are going to the right wall of the ascending aorta, and again, we sent it, and we crossed the defect with one shot, and we put the device, and it was closed. It took again like 10 minutes. It's incredible, and we are utilizing it routinely now, and we are doing for the aortic valves CT, and we put the angulation there, and we are crossing it very easily. And this is another image. You can see how CT can help you, because sometimes TOE is really very challenging, and you cannot, I couldn't see, for example, for this case, that much clear on the 3D images. It was very confusing, but on CT you can understand that this patient had an infective endocarditis and the aortic root and subannular part. Apparently, this patient had an infective endocarditis previously and maybe abscess. Abscess was drained maybe because this was a previous infective endocarditis case and a paravalvular leak. And the defect is here. You can measure the defect length. This is another case. Defect length, defect width, and you can decide on the device type, device size, and you can choose your angulation. So CT is really very helpful. And thank you so much again.
Very much. Okay, thank you very
Thank you
much.
so much.
Okay, now we're closing the session. Thank you very much for the audience waiting for this till the very end. Thank you for the organizing committee, and see you tomorrow, inshallah.
معلش احنا بكره ان شاء الله الليفت فنتريكل هيبقى فيه محاضره صغيره وبعدين الهاندز اون على الماشين وعلى الورك ستيشن ان شاء الله بدايه من الساعه 9 ان شاء الله.